what I'd like to do is talk about palliative care in MND. And we've got quite a lot of time. If there are things, as we're talking, you're not sure about, do wave. I'll try and spot you and we'll come back to things. I'm going to say a little bit about MND. I know most of you know a lot about MND, but just a little bit about the disease itself to start, to set the scene. What is MND? It's a progressive disease. It's disabling. There's no curative treatment. The treatments we have, we'll come to later, are best at slowing progression, at best. How common is it? It is a rare disease. 1 in 12,000, but actually that's quite a lot of people. I've changed my age group. It's late middle age. Most people are in their 50s, 60s, but there are patients much younger and patients on diagnosis older. Slightly more men than women, but not an enormous difference. What has changed over the years is the genetics. About 5 to 10% of people with MND will have a family history. Now, when I started talking about MND, which is an awful long time ago, back in the 1980s, we had no genes. The SOD gene, superoxide dismutase, one gene, SOD gene, well named, I think, for MND, was found back in the 1990, that sort of time, early 90s. And that's all we knew for a while. We've now got other genes, FUS, TDP, and the one that's probably most significant is C9orf72. Comes off the tongue very easily. And of the people who give a family history, about 40% will have that gene. And those families may talk of MND, but they may also talk of frontal temporal dementia. And there's a spectrum, with some people only having frontal temporal dementia, some people only having MND, and a mix across. The interesting factor is that if you test people who have no family history, 10 to 20% have that gene. And if you go to Finland, it's 40%. Because Finland apparently is a very small population that nobody moves in and out of. So it's quite a small population. So I think we are seeing a real change. And these patients will act in different ways, will develop in different ways, will probably need different treatments. That if someone has the SOD gene, they will need a different treatment to people who've had other genes. We don't know why other people are getting MND. I think probably we don't know the genes yet. And we also don't know why some people who've got the gene get the disease and some don't. I've been at presentations where people have done great mathematics that say it's 4 or 5 stimuli, things that have to happen to get MND. If you've got C9orf, that probably gives you 3 out of 5. So there's something else that's needed. And we don't know what those are. There have been lots and lots of theories, but we don't know what they are. But over the coming years, I think we'll see more and more in the genetics. And also the treatment with the genetics. There's a new trial starting with lithium, which initially, a few years ago, showed no effect. When they did some clever maths, they showed that people who have the SOD gene, it seemed to have an effect. So this is the start of actually saying, you've got this gene, this may be a treatment. The other implication of this is that your mother, father has MND, their father did, you've got an uncle with frontal temporal dementia, you can now have a gene test which may show you're positive. And what do you do with that information? Because it will be the same as having Huntington's gene. You know, do you decide at 20 you're going to have the test, get sterilised, have no children? Do you spend all your time looking to see when the first vesiculation is going to happen? medical students all have MND for the week after they have neurology lectures. Because if you stick your tongue out long enough in the mirror, it will start fibrillating like MND. You have to do it quite a long time, but all medical students have MND for that week. So how do you cope with, am I starting, what's happening? So there's real implications for patients and families. It always talks in the books of 3 different forms of MND, and the other complication is everywhere else other than the countries that were red on the map in 1960-something, i.e. the British Empire and the Commonwealth, call MND ALS. That's what everyone, the Americans, whole of Europe, will call it ALS. In America, just to confuse things, it's called Lou Gehrig's disease, because he was a famous baseball player who developed the disease back in the 30s. It's sort of like having a Len Hutton disease or some, Bradman disease in England. So, but there are these 3 forms. ALS is the commonest. It starts in about 66% of all patients. It's the upper motor neuron. That's the nerve that goes from the brain down the spinal cord. And the lower motor neuron, that's the nerve that goes from the spinal cord out to your muscle. Both are affected. It's slightly commoner in men. It's usually the older group, and you'll get muscle weakness, you'll get fasciculations, that's the moving under the skin, but you'll also get spasticity. So it's a mixed picture. Progressive bulbar palsy is about 25% of people develop the changes in speech and swallowing as their first symptoms. And progressive muscular atrophy is a much smaller group. It's mainly the lower motor neuron loss, so it's down weak arms, weak legs. It's commoner in men under 50, and you get wasting and weakness, and the prognosis is much longer. You're looking at years, 5, 10, 15 years, whereas the other group will come to it when it's much smaller. However, I find patients don't fit the books always. They very inconveniently don't have all the right symptoms and all the right systems. And many patients will have mixed pictures, and most will develop into the ALS with mixed upper motor neuron. Most will have leg, arm, and speech, breathing problems, but not all. And that was the problem of talking with people with MND. And I've had people who have said, you didn't tell us that we might get this. But another person says, you told us we were going to get this and we haven't. And so we need to say these are things that may happen, not what will happen. The other group is primary lateral sclerosis, which is a much smaller number, which is upper motor neuron lesions. So people are very spastic. It tends to go upwards and later affects speech and swallowing. It's again a longer prognosis, but quite severe effect on people. The prognosis is said to be the 2-3 years, but 25% of people with MND are alive at 5 years, and 5 to 10% at 10 years. Now, the one person everyone knows with MND in the UK population is Stephen Hawking, who is 50 years now from diagnosis. He is one extreme of the spectrum. I had one lady who was diagnosed while she was pregnant. She was about 8 to 10 weeks pregnant. She had a termination of the pregnancy and she died before the baby would have been delivered. So she deteriorated in 6 months, died. That's one end of the spectrum. Stephen Hawking is the one out there somewhere. But it's commonly 2 to 3 years, and we have to remember it's about a year usually from first symptom to diagnosis. There is no curative treatment. There is riluzole, which delays progression, said to extend life by 3 to 6 months over 18 months. And there is now a Neurone, which again slows deterioration. The evidence is pretty small, and neither are going to make enormous differences. So that's where I think that palliative care comes in from the time of diagnosis. This, hopefully everyone knows the World Health Organization definition of palliative care. I always think it's like an examination question. Every word has been pored over. You know, a committee spent 3 years coming up with this. So an approach that improves quality of life of patients and their families. Facing problems associated with life-threatening illness, MND fits that. Through the prevention and relief of suffering, early identification and impeccable assessment. I know who put impeccable in. Try explaining impeccable to a group of Polish doctors. Actually, if you went down to Ormskirk and asked people what impeccable means, you might get some interesting responses. But I know it's a good word to be used, but not very good internationally. Careful assessment, treatment of pain and other problems, physical, psychosocial and spiritual. So when we're looking at MND, we need to look at all those issues. There's the physical issues, the symptoms, we'll come to one or two. The problems of positioning. The nurses who have been involved with someone with MND will know you spent an hour getting the person comfortable and you think, I've done it. You leave the room, buzz, the buzzer's gone. And 6 hours later, with a Richter's grin, you're still trying to get that person comfortable and never quite succeeding. Or the problems of mobility. A person who just refuses to have the wheelchair until Maundy Thursday at 3 o'clock. Everything's shutting. Certainly at 5, if not at 4, because it's the bank holiday tomorrow. It's shut for 4 days, a wheelchair is needed for that, for the person's daughter's wedding on Saturday. And you've got an hour and a half to get a wheelchair. Have you had that problem? Communication issues we'll come back to. If we look at symptoms, this is large numbers of symptoms. And a lot of patients. Dysphagia, breathing problems, weight loss, pain 73%, constipation, drooling, emotional mobility, lots of different symptoms. I'm going to look at one or two symptoms. If we look at pain, why has someone got pain? In palliative care, we know the diagnosis, but we're trying to work out the cause of that symptom. So is it musculoskeletal? The person with very weak arms, his arms are pulling down on a joint, and that's causing pain. So is it physiotherapy? Is it non-steroidals? Maybe even injection into the joint? Is it cramps because someone's very spastic? Particularly someone with primary lateral sclerosis. So again, it may be getting the good position, but it may be using muscle relaxants. Or is it skin pressure pain? And that's the general discomfort of someone who's in the same position. I won't make you do it. Was followed by a very cruel nurse who made everyone in the audience sit still for 2 minutes. And everyone said, that's going to be easy. And I was at the back of the hall, and after a minute you could see everyone going, my nose is itching. I'm not allowed to move, and my left buttock's numb. I've got, and the 2 minutes, everyone was moving. Try it at home tonight. Someone with MND, the carers come in at 9 o'clock, get the person out of bed into a wheelchair and say, see you again at 1. Ish. Sorry I was 2 hours late, it's 3 o'clock, I know. I meant to come at 1, but I got caught up. 6 hours in the same position. And it's getting the right position, but that's when painkillers could be absolutely vital. I had one person, I'm sorry, some people will know some of my stories, but I had one patient who said, I am not in pain. And we said, okay, yeah, we're hearing that, but you're always needing to be moved. Yeah, that's not pain. So I said, look, 1 week on the ward round, I said, look, for me, will you take this small dose of painkiller? I think it will help you. Very grudgingly. He agreed to have a small dose of morphine for that next 24 hours. I went back the next morning and he said, that pain I haven't got has gone away. And I didn't realise how uncomfortable I was until it stopped. Now that was important for him, but it was as important for his family, because instead of moving him, shifting him, doing things all the time during their visit, they talked and did things because he was comfortable. So it's thinking through that wider issue. Now at this point, I remember giving a talk to neurologists, not recently, many, many years ago. At this point, all the neurologists had gone, well, he obviously kills all his patients. Give them morphine and they'll all die. So I did a study. Now this is always its 20th anniversary. You know, evidence-based medicine does take a while to get through the system. It's 20 years off, got its 20th birthday this year. I looked at the patients we'd looked at after. The median dose was 60 milligrams, so not a huge dose. But the mean duration of use was 95 days. So some people were starting on Monday and dying on Wednesday, but that Wednesday was 3 months later. So used carefully, we can say it's safe. And then breathlessness. People will develop respiratory muscle weakness and diaphragmatic weakness. And how can we help that? We may help with positioning, we may help with opioids. And we're more aware of people having respiratory failure issues. Now they may talk that they're not sleeping, that they've got morning headache due to CO2 retention, that they're sleepy in the day, they're not eating, their personality's changed, or they've got nocturia. I'll show you a man in a minute who, when one of the nurses visited, when they came back, they said, it's really sad he's got MND, he's now got prostate problems. He's up every hour. Little bell rang in my brain. I went to see him. He was getting up to pass urine every hour. That's because he was waking up every hour. And being a good Englishman, what do? I think I better go to the loo. He had all these other symptoms when you asked. He started on non-invasive ventilation, which is the one treatment that we can suggest. And his prostate problems went away. I cured his prostate with non-invasive ventilation because he slept all the way through the night. Felt better during the day and ate breakfast for the first time for 6 months the day after he had his night of non-invasive ventilation. Because he wasn't hypoxic during the night, his CO2 wasn't raised. And the reason people wake up all through the night is when you lie down flat, your diaphragm can't work as well, your chest muscles can't work as well, your oxygen level goes down, you wake up, take some good breaths, get it back up again, you go to sleep, and it goes down, and it does it all the way through the night. So how can we help? Non-invasive ventilation is one way, invasive ventilation with a tracheostomy is another way. Opioids also are an alternative treatment. And in the NICE guidance we say, non-invasive ventilation is one way of helping these problems. If someone isn't able to, can't cope with that, we've got other ways of helping. This is the man whose prostate I made better. But the problem with non-invasive ventilation, it helped his breathing. But his arm still got weaker. His swallowing got worse, his speech deteriorated. On his communication aid, he wrote, I wish I hadn't started this machine. I do find that B words come out quite well, do you find, with MND? B words come out pretty well, regardless of speech problems. But I can't stop it. This was 20-something years ago when we weren't talking withdrawal of treatment so much. Because someone will deteriorate. And we'll get to the state, for some, where they go to A&E at 3 o'clock on a Sunday morning, when all emergencies happen. See people they don't know, someone in respiratory failure, they're saying my non-invasive ventilation machine's not working. It's not that's not working, it's this that's not working, and it's they're into more respiratory failure, and someone does a tracheostomy and then thinks on Monday morning, what have we done? This man actually went into hospital for a knee operation, and at the end of the operation that bag was supposed to go in and out, and it didn't. And he had to have a tracheostomy, he was on the ventilator, and then someone said, oh, his hands look a bit funny, don't they? And they were a bit wasted, and oh, look, after his reflexes, and they were all abnormal. And they said, have you been breathless? He said, yes, I've been telling people for 18 months I get breathless. I had a chest x-ray and they said it was normal and I couldn't be breathless. But he was getting incipient respiratory failure. And he ended up with a tracheostomy. His quality of life was quite good. On the bottom there is his glass of beer. I had to take his glass of beer, he insisted that it was included. Because that was his quality of life. Behind me is his wife, who is like this. And people have done studies of people on tracheostomy and found that a patient who was totally disabled, not able to move, not able to communicate, dependent on a ventilator, will put their quality of life at 7 out of 10. Their family put their quality of life at 3 out of 10. There was a very good film on Channel 5, I think it was, about 18 months ago of a son who took a video diary of his father with MND. And you can see the family disintegrate because he insisted on having a tracheostomy. And you can see the family disintegrate as he needs the increased care and is needing more and more care. It's fascinating. The wife goes from someone who's looking smart, well-dressed, looking after herself, to someone who's dishevelled and in a mess. And obviously we can keep someone alive for ever, or nearly so. In Japan, 1/3 of people with MND have a tracheostomy and are fully ventilated. And people live for 5, 10, 15, 20 years. After 5 years, communication is limited for the majority, and after 10 years, some cannot communicate at all. When I was at a conference last year, a man rushed off to tell me that he was inventing a new intervention to help people communicate. It was going to be a small thing to be inserted into the anal sphincter, which would pick up the anal sphincter, and you could then clench 1 for yes, 2 for no. I went. I also was sort of, not sure if I can do it. Yes. There's something about quality of life. And we're seeing people with non-invasive ventilation and with tracheostomy who are saying, I don't want to carry on with it. And if someone has capacity and says, I do not want that treatment, we should stop that treatment. If they have lost capacity but made an advanced decision to refuse treatment before they lost capacity, we should stop the treatment. This man, before he went home from the hospice, made a very clear advanced decision to refuse treatment, saying, I do not want to go back to any hospital ever again. If my tracheostomy falls out, blocks, I want to be at home. Do not put me in an ambulance under any circumstances. And if I can't communicate, I don't want to carry on. He deteriorated one morning and died. But some people need to have their non-invasive ventilation withdrawn. If we just stop it, there is a high probability they will get breathless, particularly as people have their non-invasive ventilation initially at night and then a bit more in the day and more in the day and more in the day, even to 24 hours. And if we stop, they will become breathless. So we need to give medication before we stop it, to stop those symptoms happening. Ethically, legally, there is no problem with that. This bit is fine. This bit says you switch button off, machine stopped, person died. David, you killed that person. This bit was fine. I've done all the ethics, it's all fine. But this bit says different things. I had a little bit of talking when I've done that between my head and my heart. And within teams it can be very difficult because people have different attitudes, different feelings. But we're going to face that more and more. And more discussions need to happen. If you read the nice guidance, which I'm sure you all have and will, so beautifully written. I didn't do it, I just chaired the group. But we say we need, when we're starting to think about non-invasive ventilation, when we started, we need to say what's going to happen later. We don't leave it until there's a problem. This is a treatment that's going to help you, but in the future you may want to stop it. How are you? What would you like us to do? Would you like to make decisions? Would you like to put that on paper? Would you like us to be clear? Then swallowing problems. Someone can't swallow. Well, first of all, think if someone's not eating, why not? You know, if their arms are here and some friendly person comes, ward auxiliary brings and puts a plate in front of them in the ward, and then 20 minutes later takes the plate away, and they're looking at it but can't reach it, they will lose weight. So always think, is there basic things of actually getting food into someone's mouth, and then how they chew, move it around, swallow it. So it is careful feeding. It's helping someone with feeding, and that's a real art. And it's not an art that's taught very often. Some people seem very good at it. Others would be like me and take a bigger spoon, put more on it and stick it in further. You always know what the person's had for breakfast because you can see the Weetabix on the wall opposite, where it gone. Altering the consistency, soft, solid things, having time to eat. I had a man who went on a holiday and lost weight because in a hotel you go down at 1 o'clock for lunch and you're supposed to be out by 2. He'd hardly started. So they were taken out, they had to go out and he never had his food. But we might need to think about gastrostomies, PEG, earlier rather than later because someone's breathing may affect when they have their gastrostomy put in. If your breathing is deteriorating, your morbidity and mortality of having a PEG put in increases dramatically. So if someone has swallowing problems, we need to think about it sooner rather than later. And it needs to be a process. I think it's have you had problems with swallowing? Have you ever heard of other things to help that? Have you heard about a gastrostomy? Would you like to meet someone with one? Would you like to see the dietitian to show you one? Now we start need to make a decision over a period of weeks, months, rather than where we can fix it up for tomorrow morning. I've got to get the application in by 1:30. So you've got 28 minutes now to make a decision. Yes or no? Yeah. It's usually no. If it's been talked about before, it gives the option to be aware to go through that process. But obviously if you can't swallow, you tend to dribble. You produce a litre of saliva a day. So I think that's a nice big bottle of water pouring down your front every day. And what happens if you dribble? People talk slowly at you. Because you must be mentally impaired. Try doing that to Stephen Hawking. I think he's got a one button off message. So that's, it's really demeaning, really difficult. You get a sore face, you get a sore front. So anticholinergic medicines, tricyclic antidepressants have good side effects of drying up the mouth. Botox injections can be dramatic. It's not the be-all and end-all, but I had one person who went from 5 boxes of tissues a day to 5 tissues a day. It was dramatic. So it's always thinking, what are these problems? How can we help? And then with communication, we need to involve speech and language therapy. We need simple things. If someone can use a pencil and paper, that may be the best thing for them. But be aware of what happens. I had one man who used to write things, and his wife would then look at his pad, and she'd go back a few pages and say, "See, when's the old bat coming to see me?" That was a conversation from 3 hours ago. It had gone, but it was still there. I like those magic magic slates, so you can just get rid of it. They're posher ones now, more electronic. It may be a communication system with a laptop. Your eye gaze system with just using your eyes. But you may need a laminated piece of cardboard with too hot, too cold on to have in the shower. Because you're not going to be able to take your light your iPad, or you're not wanting to take your iPad into the shower. So think of simple things so that people can still communicate. This was someone who very easily used his iPad. He had a speech app on it. He used to have really rude jokes when the speech therapist and the dietitian went to see him. And loved to see their reaction. He also had, "I would like 5 first-class stamps on it." And I kept on wanting to ask, how often do you use that? It's not a common thing that you do. And if before he came to see me, he'd write things down. But it's very slow. You see Stephen Hawking giving a lecture, but that half-hour lecture may have taken 2 or 3 weeks to prepare. And don't interrupt. It's so tempting. I had a lady who were about to talk about switching off a ventilator, and she wrote, "Communicate with her toes. Yes, no." Through a spelling chart. Am I going to? I was just about to say, "Yes, you are going to die," when she said, "Go home." I was that far off. Luckily, I took breath. So don't finish the sentence. I'm afraid with Brits, we need a bit of help to say, don't be so nice. Because the English do tend to say, if it's not too much bother and you're passing, could you get me? If it's not, it's okay, a cup of tea on your way back. And if they're speaking that or communicating that on a communication age, you've lost the will to live when important bit comes. So encourage people to say, "A cup of tea now, please, if you can." But also, communication is speech, it may be understanding, and there may be cognitive change. Again, 30 years ago we would have said no, there's no cognitive change. Interestingly, if you go back to the first papers written about MND back in 1874, it talks about dementia. It got lost for 100 years. About 10 to 15% of people will develop frontotemporal dementia, and up to half have evidence of frontal lobe change and cognitive change. That may not be significant for all, but may be very significant for some. And increasingly, people are talking of who have ALS with cognitive impairment, with behavioural or the frontotemporal dementia. Because it leaves the frontal lobe is the bit that does your decision making. So sometimes, I'm sure any of you have been involved with someone with MND who've talked about a gastrostomy and someone won't make a decision. It may be they can't make a decision, not they won't make a decision. There's the issues of risk-taking. There's things for families. How do we make decisions? How do we do day-to-day coping? We had one lady with frontotemporal dementia who, when her husband said, "We're going to the shops later," she would put her coat on and be at the door ready 2 minutes later. This was at 7 o'clock in the morning. And we had to help him to think, I'm going to say that at 9:05 when we're getting in the car. He said it was a little bit like saying, I'm going to take the dog for a walk, and the dog's there ready with a lead. There's that immediacy, and there's loss of language as well as communication. And for professionals, how do we assess some symptoms if someone's cognitively impaired? How do we keep someone safe? How do we help with those decision making? I always have the biggest arguments I have within our team were with capacity issues for someone with cognitive change and MND, because they can probably do the first bit of the capacity, understand the question. They can probably make the decision, but they couldn't weigh up and understand the decision in between. We had one lady who was insisting that her 14-year-old son took her to the toilet 3 or 4 times a night. And the daughter said, look, Mum, you would have cut your arm off for him 2 years ago to not put him through any trouble. And now you're making him do this. You're not the same person. But she was very, I want to be at home, I want my son to look after me. And it sounded all very clear, but that bit in between of how that decision was made was very different. And then thinking of psychosocial care, it's a disease of multiple losses, physical, cognitive, emotional ability where you tend to cry or laugh. Showed that first slide, 23%. People think they're going mad. And if I suspect someone may have emotional ability, I'll ask about it. Do you ever? And they'll say, oh, I do. I don't understand it. Well, I do understand it. We may have some things that can help for treatment, but understanding may be the most important. There's the fears about it, the disease. I think we're going to see a lot in the press in the next few months about assisted dying again. And there will be people with MND or talked about with MND saying, I do not want to choke to death. I want assisted dying. And if you put MND into Google quite early, you get Diane Pritty's comments. Remember, she was the lady who went to the courts to try and get assisted dying. I do not want to be tied into a wheelchair with saliva dribbling down my front until I choke to death. Not a good thing to read when you've just seen the neurologist for the first time. So there's that fear. Or they're with someone who has had familial, they may have their memories of their mother, their father dying of MND. And there's the fear of death and dying. We're not very good in this country. You know, how do people die on the telly? There's the Henry VIII, I was thinking of. I love you, my dear. Or there's that, because I've been shot. You know, something horrible on the cop programmes. You know, that's how people die on the telly, and that's people's knowledge. Nobody has diarrhoea, you know, on EastEnders. Have you noticed? You know, no one becomes incontinent or has nasty things going on. And people are fearful of what it all involves, what it means, what will happen. Or they read and hear things, how awful MND is. The evidence is that choking to death is very, very rare. And we've now got papers with over 500-600 patients with no one choking to death, but it's still there in people's minds. There's the issues within the family, the changes in roles, the losses, their fears of the disease, their fears of death and dying, financial issues, I think, are becoming more and more. We had one lady who applied for continuing care. Unfortunately, I nearly wrote on the letter supporting her application, I'm afraid this lady is still breathing. Because she was peg-fed, communicated by moving one toe, completely restricted to wheelchair and bed, but she was breathing unaided. And that's the only reason I think they could say that they wouldn't give her continuing care. It took 4 appeals to do it. And PIP can be quite a difficult thing to get PIP through. Or the emotional changes. And do we talk about palliative care, death and dying is no problem. We don't talk about things. OTs tend to talk about more. Many OTs here, because they have to talk about beds. And you have to start saying about bed partners. You know, that has an implication. Or the riser recliner chair comes, it gets broken. And you don't ask too many questions of how it broke, because it was only meant for one person sitting in. The rest of you have worked it out, I guess. But, you know, do we talk about sex and intimacy and being there? And this is what happens, of course, if you're reading a book with your sister-in-law with no clothes on. May it be a warning to you. If you are sitting reading a book with your brother-in-law or sister-in-law, beware what might happen, especially if you've got no clothes on. But, you know, do we talk about sex? I did a little survey of patients, and one man wrote, "Thank God that's not a muscle." And one lady wrote, "I don't know who I am when I put my husband to bed. Am I his nurse, his lover, or his wife?" And that hit me because I know at the Wisdom Hospice where I worked, we'd say, "It's lovely, Mrs. Jones put her husband to bed last night." There's a chance that some helpful person would have banged on the door and said, "Can we help?" Which might have been appropriate, but might have been very inappropriate. So do we think of all those aspects? And then spiritual aspects, that's not necessarily religious, it's that deeper meaning of life. It was Claire Short. Remember the MP who did a lot on page 3 girls? I'm showing my age, I know, sorry. She was on Desert Island Discs one time talking about the death of her husband and her father, and said when her husband died, she blamed God. And she said, "I've never believed in God. I don't believe in God. I don't think I ever will believe in God. But when my husband died, I blamed God." So it's that deeper, it might be religious, but it might be the why me. Now, if it's genetics, why me is my mother and my grandfather. But it might be the fears of dying and fears of death. What's going to happen to me? Are 2 murders, 4 illegitimate children and 5 marriages? What's going to happen when I get to the pearly gates? I haven't got an answer to that, but we can hear it and listen to it, and there might be a role of a priest giving absolution. And the fears of death. Is that what's going to happen before I die or after? I can answer the first bit, the next bit I can't, but we can hear the issues. And it's very much as what comes across is multidisciplinary, multi-agency. Do we ensure it's coordinated? Have any of you had a patient who a nurse and a physio and an OT go in, and they all think, "Oh, this person's got problems with mobility and bathing." And the physio thinks, "I'll get the wheelchair. That's, someone else will do the other bathing bit." And the OT thinks, "I'll do the wheelchair." And the nurse says, "I'll do the wheelchair." And 8 weeks later, reality, the wheelchair comes, but there's still no bath aids because no one's talked to each other. Or do we overwhelm people? Where I had one patient who said, "Look, a man in a suit, that was me, a lady in green trousers, a lady in blue trousers, a lady with a big bag of food, another lady with a machine that talked, another lady with a big diary," that was the social worker. They've all been to see me. I don't know what is going on. I've run out of biscuits. I've run out of tea bags. But it's all too much. Can we work out ways that we can do it in a way that someone can cope? And do we support carers? That may be family carers, but also social services carers. I did a little survey where I found I visited patients or seen patients 15 times. Good old me. Physio had been 25 times. They'd been to the day hospice 30 times. And then we suddenly thought that the care from social services had been in 3 times a day for 6 months. And no one had thought how that was for her, seeing the person who needed some care to needing total care and having dementia issues. Do we look at all carers? And then as end of life, we look ahead. Do we anticipate it? Do we communicate that? Are we supporting everyone? Are we looking at making sure the symptoms are really well controlled? And in the NICE guidance, we say that discussion on end of life should happen whenever the person asks. And that may be a diagnosis. And certainly that we need to be thinking at earlier stages, looking at advanced care planning. That can be what may happen. Do we need to look at advanced care plans, advanced directive, advanced decision for abuse treatment, looking at powers of attorney? It can make life a lot easier and give that person a voice, even if they lose capacity. And we said as when the end of life approaches, we've actually put more care in, so that that wife or husband can be wife or husband, rather than continue as carer. And that we have, if we haven't got communication aids, is there something we're getting quickly? Have we got a specialist palliative care involved? Are there particular things we need? Have we got medication ready? Have we thought and are we prepared to support families and carers in bereavement? And when we're looking at a crisis, we need to prepare, to anticipate, keep cool, calm and collected. Yeah. Oh dear, we seem to have got a bit of a problem here. Because if we go, ah! that doesn't help. We have to be like the swan. The feet might be doing this under the water, but nice and cool and calm. Let's work out what we're going to do. And that may be when an injection of morphine, midazolam, something to help secretions may be needed. And to have those available. And the MND Association produced the box for the medication to be stored at home with buccal midazolam, so that if family members might be able to give that, if they're taught and explained if that person won't be able to have a nurse coming quickly, so that people are prepared. It's talked about, they know, and everyone is prepared. That started because a very famous person in the association became ill on a Sunday morning. A local GP came in, the person was hardly rousing, couldn't swallow, and he left a prescription for amoxicillin capsules, which the person couldn't get till Monday anyway, because all the chemists in their area were shut. And they died that night in quite a distressing way. So the association came up with the idea of having medication quickly available. So to finish, we're looking at symptom control, psychosocial care, support for patient, family and carers. Doctors have no problems with stress. We commit suicide more than most people. We have a high alcohol rate, high divorce rate, high drug use, but we cope with stress perfectly well. Nurses, I'm not sure. Seeing by our local hospital how many people are having their fifth fag before they go on duty to get their nicotine levels up as high as possible before they go through the gates. Might be some issues. So do we support each other within the team? Do we talk about the difficulties and some of those issues that we face? It's not an easy disease. It may be quite difficult. In our multidisciplinary team meeting we used to have, we would, sometimes someone would say, I found her difficult. And you could see everybody else in the team going, oh, thank goodness. I thought it was me. I thought I wasn't doing it right. So you find it difficult. Oh, it's awful. Whatever you, and you could start saying, and that's probably when there was cognitive change, looking back. But we could talk about it and support each other and come up with a plan. Now, apologies, some people have seen my picture from Skegness. I do have problems explaining this to doctors in Poland, where Skegness is. You know about Skegness. It's my vision of hell. Uplands of Skegness. Please. Just put me out of my, take me anywhere. But this was a lady with MND. It was sent to me, having a good time, out every evening, see you soon. And that's the lady who got the postcard written to me. She had MND. She was restricted to a wheelchair. She only used a communication aid for communication. She had a peg. You can't see it. She had a peg. And her speech was very, very limited. She went to Butlins with her husband, and luckily with the daughter, because the husband went to bed at 10 o'clock, because he'd always gone to bed at 10 o'clock. Are there other men like that? A man of a routine. So the daughter said, let's go and see what's going on. So they went off to the club, nightclub, and they found that if you pushed a wheelchair around to the nightclub, no one minded. The only problem was everyone said, can we have a go? And they all joined in. In the nightclub, she was enabled rather than disabled because she could use her communication aid. Everybody else was bellowing into each other's ears. She just said, gin and tonic, please. And she found a gin and tonic, went down the peg very, very well, thank you very much. Had quite a quick effect. Couldn't fall over because we were already in a wheelchair. But it had been very easy for that lady to say, I can't talk, I can't swallow, I can't move, I can't do anything. What's the point? But because we were able to help with those issues and move on, she could actually have a good quality of life. Thank you very much. There's some of the